Good morning. The Health Insurance and Long-Term Care Issues Committee is called to order. Thank you for joining us. We're grateful to be able to kick off this NCOIL session with the Health Committee. Wanted to especially welcome the legislators that are here for the first time. Glad to have you with us. So first we will ask for a motion to waive the quorum requirements. Is there a motion?
So moved.
We have a motion to waive. Is there a second?
Second.
Is there a second? Any discussion? All in favor say aye.
Aye.
Opposed say no. Motion carries. Next, let's consider the minutes of July 18th, 2024. Discussion to approving the minutes.
So moved.
We have a motion to approve minutes. Second?
Second.
We have a second. Any discussion? Seeing none, all in favor say aye.
Aye.
Opposed say no. Motion carries. The minutes are approved. Before we get started with the agenda, I'd like to remind everybody that if you'd like to speak on an issue and you're not a scheduled speaker, you can fill out a testimony slip and give that to the chair or one of the staff, and we will make sure that. We're going to go a little bit out of order today, so we're going to start with item number 6 first, and this is a presentation on the prior authorization reform landscape. And let me begin by welcoming and recognizing Senator Walter Michel. Yeah, Senator Michel.
Thank you, Mr. Chairman. This prior authorization is a subject that the state of Mississippi passed a couple of years ago, and we thought it was very significant legislation, and I'm thankful to see that the committee is addressing this, and we would like to think that maybe the Mississippi model legislation will be a starting point for us, and I appreciate you considering this subject.
Thank you, Senator. Now we'll hear from our presenters. First, we'll hear from Emily Carroll of the American Medical Association, and then Miranda Moulter of America's Health Insurance Plans. We'll hold questions until they're finished. Emily, please go ahead.
Wonderful. Thank you, Chair. Great. I have some slides, and I think the clicker. There we go. Great. Well, thank you so much for having me. Prior authorization is certainly a priority issue for the American.
Emily, will you pull that mic a little bit closer
Yes,
to you?
Sorry. Thank you. Better. Great. Well, I'm Emily Carroll with the American Medical Association, and prior authorization is certainly a priority topic for us. We've been working to address this issue for many years, largely in the states up until recently. Every year we put together an annual survey of physicians to sort of assess the impact of prior authorization on them and their patients. And as in previous years, the survey results continue to show both patient harm and physician harm, as well as impact on the healthcare system and employers and employees. This year, we always kind of initially focus first and foremost on the patient harm because we believe it's significant. And this year we continue to see that. 94% of physicians report care delays because of prior authorization, and 78% report that prior authorization has led to treatment abandonment by patients. Maybe most concerning is that nearly 1 in 4 physicians report that prior authorization has led to a serious adverse event for their patients. And this can include hospitalization, long-term or a permanent impairment, or even death. We also look at the impact of prior authorization on physicians. It's draining and exhausting our physicians and their practices. Physicians spend nearly 2 business days each week completing prior authorizations, and they're reporting that the number of prior authorizations continues increasing, and nearly all physicians report prior authorization is leading to burnout. And I'll really want to stress that this is all happening against the backdrop of a severe physician shortage in the states and nationally, and the growing corporatization of healthcare. And prior authorization is certainly impacting and leading to this environment that we're seeing these issues with. Also, prior authorization is impacting employers and employees. Almost half of physicians report that their patients' job performance has been impacted by prior authorization. So that's, a result of absenteeism or a decrease in function due to care delays and prior authorization impact. And then finally, we find that prior authorization is increasing costs for the whole healthcare system. The impact of it is really causing a greater utilization of services, repeat office visits, ineffective initial treatments, and more hospitalization and ER visits. So what are we proposing to do about it? The AMA is offering a number of solutions. We have model legislation that we've seen being introduced in some of the states. But really, we've kind of bucketed our solutions into a couple categories. First, faster response times. We really need to address these care delays. The AMA would say 24 hours as a turnaround time for urgent care and 48 hours for non-urgent. And we really focus on those hours rather than business days. And we're really strong proponents of the use of APIs and other standard transactions to help automate the process. But we really stress that automation has to be done in the context of other reform efforts, because we're not just trying to get more prior authorization done faster. We also are really looking at reducing the volume of prior authorization. So as I mentioned, physicians feel that prior authorization just keeps growing. And we're really looking at solutions that would reduce that volume and sort of bring prior authorization back to kind of its targeted or initial goal and kind of targeted utilization management. So some of our options here are those that have been passed in Texas and other states, kind of gold carding, which is the idea that if you have high approval rates on certain services or episodes of care, maybe you wouldn't have to do prior authorization for those services. And we see a lot of states and others looking at sort of eliminating prior authorization generally for some services that may not kind of make sense, preventive care or other types of services. We also would look to ensure the clinical integrity of prior authorization. So on the plan side, the reviewer being a physician who has experience treating that type of patient or caring for or doing that type of care. We'd also like them to specifically be a licensed physician, because really when you're making a medical necessity determination, you're really participating in the practice of medicine. And then also we want to make sure that the clinical standards that are being used to do these prior authorizations are not proprietary and really based on national medically recognized standards of care, which are most national medical specialty societies have developed. And then we really like the concept that a lot of states are pursuing around data collection. So kind of seeing what kind of behind the black box of prior authorization, what are the rates of approvals, what are the rates of denials, what are the response times, how often are things approved on appeals. And so, we think, first of all, that makes it easier for patients to make informed decisions about their plans, but also for policymakers to make more targeted reforms in the future. Continuity of care is a big issue. We've seen many proposals that look at ensuring when patients switch plans, they're able to continue on the medication or continue on the service as they switch for a period. And then we want to prevent repeat prior authorization. So sometimes you'll see a kind of stoppage in care while a patient has to go back and get a prior authorization on something they've been stable on for a long time. And then just general transparency. What are the criteria? Ensuring that once you have a prior authorization, the plan's not going to go back and not cover that service. Real clarity in the reasons for an adverse determination when it comes to the patient and physician. And then just more clarity around the appeals process, which we hear is often a difficult journey for many patients. So some of you, and I think we've talked about this before, many years ago, the AMA, Blue Cross Blue Shield, AHIP, the Medical Group Management Association, and the pharmacists came together and created a consensus document, which kind of looked at maybe some of the low-hanging fruit around prior authorization and what we thought we could kind of accomplish together voluntarily. Unfortunately, we haven't seen a lot of progress in that space, and we're still hoping, that the promises of that consensus statement are realized. But really, I think the states have led the way on prior authorization reform. This is just a map of some of the states that passed legislation this year, enacted legislation this year. Some of these states like Wyoming, Wyoming, Colorado, New Jersey, DC, Maine. They enacted some pretty comprehensive reforms this year that look at kind of all of those, or a lot of those solutions I talked about just a few minutes ago. And then we're seeing some progress on kind of new ideas. Minnesota took some steps this year after having really strong legislation on the books. They went a step further this year and decided to start looking at how to pull certain services and just, prevent prior authorization in them. So some cancer care, mental health services, those sorts of things. Vermont did something similar where they will prevent prior authorization on primary care services going forward. So we're seeing some innovation there. And I'll mention just California also passed a bill that incorporates, or that's really looking at the use of AI in prior authorization. And they will ensure that if a prior authorization is denied, a physician is making that determination rather than the algorithm. I'll also mention that there has been some progress at the federal level, which we are excited to see, and I think really builds on the work that a lot of the states have done over the last several years. There is a new Medicare Advantage rule that is in effect as of January 1st this year that makes some significant progress around clinical validity and continuity of care in the prior authorization space. And then there's one more rule that some aspects of it will be adopted over the next, in 2026 and 2027. But this one is much broader, and it applies to Medicare Advantage, Medicaid, or MCOs, and QHPs on federally facilitated exchanges. And these reduce the response times that plans are allowed to respond on prior authorization, and it really takes automation for medical services a step forward, which I think some states are really looking at adopting. And then there's a lot of transparency requirements out there. So I think states have a real opportunity with these new federal rules to kind of bring their requirements at a minimum up to these federal standards. And then, of course, there is legislation that is pending at the federal level as well that, again, looks at a lot of the state efforts and attempts to apply some of those to the Medicare Advantage space. So I will stop there and hand it over to Miranda, and I look forward to your questions.
Thank you, Emily. We appreciate that presentation. Miranda, go ahead.
Good morning.
Good morning.
Let's see here. Can keep going, maybe? I apologize. Here we go. Well, thank you for having me. Miranda Motter with AHIP. I'm Senior Vice President of State Affairs and Policy. It's probably not going to surprise you that on all things prior authorization, Emily and my organizations don't necessarily see eye to eye as it relates to the value of prior authorization, which I assume is why I'm here, right? We're both here to sort of share those perspectives. I will say, though, that, I do think that there is probably a bright spot. I do think that there is probably some agreement as it relates to what, quite honestly, both of our organizations view as a major barrier to making sure that the administrative burden for providers is reduced as it relates to prior authorization. So I'll spend some time talking about that, but really wanted to speak really about 5 quick areas this morning. First and foremost, the value of prior authorization. Secondly, and Emily spoke to it a little bit, but I do think it's incredibly important to spend a few minutes on that consensus statement that she talked about. Third is where I want to spend some time about where I think there may be some alignment and some real opportunity to, again, reduce administrative burden for providers, but at the same time doing so in a way that doesn't jeopardize patient safety, patient care, patient affordability. And then share really some places where states, where all of you are leading the way as it relates to reducing this barrier. And then close with just a couple of insights as you all may be looking at proposals moving forward, just a couple of recommendations and suggestions as it relates to that. So with that, why do health plans use prior authorizations? Health plans advocate for the people that they serve by ensuring that the right care is delivered at the right time in the right setting and covered at a cost that patients can afford. That's essentially why prior authorization exists. And at the outset, I think it's really important for me today to say that doctors, so Emily's members, provide important care and life-saving treatment. But I think we all know we're all impacted by low-value care. Low-value care is care that has little or no clinical benefit, or where the risk of harm for the care outweighs the benefit. Low-value care has a significant impact on our country's healthcare system. But more importantly, it impacts patients, and we can't lose sight of that. So we've all seen the studies, the financial impacts of low-value care. Here is one, a JAMA study that estimated 25% of all healthcare expenditures is due to waste in the U.S. system, and of that total, it's estimated that $75 billion to $101 billion is related to overtreatment or low-value care. Other studies show that 30% of healthcare spend in the U.S. may be unnecessary, and it may be harmful to patients. So low-value care doesn't just have this financial impact. It impacts patients. It may expose them to harm. It may expose them to additional out-of-pocket costs. It may expose them to lower quality of life. And really important here is low-value care impacts how other doctors have to provide care. 87% of doctors have reported negative impacts of low-value care. They have also reported that at least 15 to 30% of medical care is unnecessary. So in other words, doctors have to fix care of other doctors, and that impacts patients. Medical knowledge doubles every 73 days. It doubles every 73 days. Primary care doctors would have to practice 27 hours to keep up on all of those changes. And so that's really why it's important that health plans, doctors, hospitals all work together to make sure to reduce that low-value care and protect patients from unnecessary harmful care and costs. So plans, what do? Plans are doing this through a variety of strategies. They enter into value-based arrangements with providers, where those providers are actually holding themselves financially accountable for the quality of care that they're providing their patients. Plans share real-time provider feedback so that it helps those providers understand if they are operating as an outlier, if they're not following clinical evidence-based standards. And then last, plans use targeted evidence-based prior authorization that focuses on those clinical areas that are prone to extreme variation in costs or misuse that harms patients or saddles them with unexpected costs. The prior authorization process, I have to say, we all agree can be burdensome for all of us, for providers, for patients, for plans. And again, that is why it is incredibly important that we all work together. This is a slide that you just saw from Emily. And this is exactly as she indicated what we did. In 2018, we all came together. So all 6 of these national associations came together and in a really public way committed to improving prior authorization. One of the things that I do want to point out in this consensus statement, because it was significant, is that it recognized not only that the prior authorization process is burdensome, but it also recognized all of us that prior authorization was important. And you can see, as it says in this consensus statement, and it's important because there's wide variation in medical practice. So as trades, all of us agreed to 5 areas of opportunity: to selective application, program review, transparency and communications, continuity of patient care, and really importantly, we all agreed to improve automation. That was an incredible, as Emily, I think, tagged it, a real low-hanging fruit. So what have health plans been doing since 2018 to take action? They have been taking action. And again, I think it's really important to recognize this, because I think that you have probably heard about this consensus statement in your states. You have heard that plans may not have been taking action, but they have. Plans have been leveraging prior authorization by using electronic systems. A survey of our plans on the use of prior authorization in 2019 and 2022 showed that more insurers are streamlining their prior authorization electronic process more than ever before. Plans are also providing support to providers. They're helping them understand why using outdated manual systems is really hard on them. It's an administrative burden, but it also doesn't achieve the best in terms of patient care. In 2020, and I think I've spoken to this before, AHIP and our partners launched what is called the Fast Path Initiative, and it actually took technology into physicians' offices and helped them understand if they used electronic prior authorization, what it meant. It meant faster time to decision, faster time for patient care, better understanding in terms of when prior authorization was needed, and the more the providers used it, the better they said the system worked for them. It also meant that there was less burden from phone calls and faxes, and so it was really important. You'll see here just a really quick case study of Elevance where it actually showed that using electronic prior authorizations really is quicker. The other thing I will say just real quick is they're also waiving and reducing prior authorization requirements as providers take on financial risk. I mentioned that. More plans are using gold carding programs based on ongoing provider performance and consistent adherence to evidence-based standards. These programs, however, the gold carding programs are most effective when they're targeted, their provider performance is closely monitored, partnered with risk-based accountability, and they're used for certain services where the clinical guidelines are clear. So let's talk about where there may be some real synergy and where we may align. I think Emily and I can both agree, right, where this place where automation was a real opportunity, which is the major barrier today. So while health plans are building and offering electronic prior authorization, a significant percentage of providers are still using fax, email, and mail. And I think Emily's own survey showed that it was reported by her providers that the most common way they're submitting prior authorizations is by phone. So despite the fact that if they used electronic prior authorizations, it could be quicker, as I said, quicker decisions, quicker patient care, better understanding of when it's needed, we're still using outdated manual systems. We have to change that. We have to improve this two-way process by providers, and I really think that this is a bright spot as we think about next steps. States here, as I said, are already leading the way. They're already understanding that this is a barrier. Not using a two-way electronic system is a real barrier to moving forward. You can see here over the past few years, at least 9 states and DC have passed this two-way legislation, so it not only requires the health plan to build and make available the system, but it requires the provider to use the system so that we're not building a bridge to nowhere. Here, and I won't spend much time on this because Emily talked about it, certainly not only are states leading the way, but there's certainly a lot of activity at the federal level to make sure that this electronic prior authorization, this technology, the interoperability, that we are building bridges to advancement. The federal rules, as Emily talked about, will require health plans to create APIs, but it'll also importantly require providers to build this workflow into their electronic health records so that they can, again, use this real-time information. I think we all believe that this is really encouraging. So again, here in closing, just a couple of thoughts. I can't stress prior authorization is an important tool. It helps make sure that patients' access to coverage for safe, effective care is supported by the most updated clinical guidelines. Important considerations, I think, for policymakers as they're objectively evaluating proposals are the providers in your state actually using electronic prior authorizations, or are they using phones to submit their prior authorizations? So does that proposal actually build a bridge to somewhere? Will the providers be held accountable for high-quality care? Are they in value-based relationships? How does the reform actually impact patient care? And essentially, in those proposals, are we tolerating a certain level of low-value care for patients? And then also, ultimately, how does the reform impact patient affordability? Again, there's some studies here that you can look to in terms of what the real financial impact is. Not only here, but I know as states have considered these proposals and you all have looked at what the financial impact is going to be, whether it's applicable to your state employee programs, whether it's applicable to your Medicaid programs, and you've seen those financial impacts. In lots of instances, the application of those proposals gets pulled from those state plans because there's a recognition that it will be expensive. And that shift then is ultimately given to the small employers that will pay for that. So again, thank you for the opportunity to spend some time with you on this really important issue. We look forward to additional conversations. I will say, I mentioned the study and the survey that we did of our plans in 2019 and 2022. We are actually in the process of updating that right now. So I look forward, it should be ready early next year. I look forward to the opportunity to come back and show how health plans continue to advance and where there may be some other gaps and opportunities for alignment.
Thank you, Miranda and Emily. Appreciate your comments. We'll open it to legislators now if you have a comment or a question. Is there any? Representative Ferguson?
Thank you. I appreciate the work of trying to coordinate. Is there any effort to harmonize what prior authorizations are required? Because, you know, in a practice, when you have 300 or 400 different health plans, and then all of a sudden one, particularly the Medicare Advantage plans, they tend to drop a prior authorization that you didn't know about, and then the claim gets denied. Is there an effort to harmonize what's required of what requires a prior authorization?
So thank you for that question. A couple of things come to mind. First and foremost, prior authorization focuses on those areas that may be, certain services that are prone to misuse, overuse, where clinical guidelines are really important to follow, and where there may be cost implications. The other thing I would say is prior authorization largely follows what your coverage looks like, right? So as a purchaser of healthcare, whether it's Medicare, whether it's the state and Medicaid, whether it's the employee or the employer in terms of employer coverage, how the purchaser of that healthcare wants to make sure that there's high quality care and that there's affordable care, it really aligns with that. So, I would say, there continues to be this focus on evaluating the services that are prior auth, but in terms of sort of industry coordination around a particular kind of service, for a variety of reasons, I'm not aware of any of that happening right now.
Representative Ferguson, I would also say some of the disconnects sometimes in an office may come from differing clinical criteria. So you may have one plan that uses a set of clinical criteria that they have purchased and manipulated, whereas another plan will use a different set of clinical criteria. So one patient service or drug could be medically necessary under that plan's criteria, and if they were on another plan, it would be different. So I think that certainly leads to some hardship on the practices and certainly the patients as well.
Yeah, but you can understand as a practitioner how difficult it is when you have hundreds of insurance plans to keep up with who requires what prior authorization. I just think the industry should get together and sort of agree on some standards, but thank you.
Thank you, Representative. So we're going to continue this discussion into next year, so we'll take two more legislators' comments or questions. Senator Lang.
Miranda, Emily, thank you very much for your testimony this morning. I did appreciate it. A few things confused me, though, because there was some contradictory stuff. Emily, you said it can take up to 72 hours for urgent prior authorization. Miranda, you said 70% are instant, 95% are in 24 hours. I know literally last week I had a urgent medical need that I had to get a test, which I'm scheduled for next week, and took 15 minutes, and we needed authorization. Maybe it was less than 15 minutes, but that's when I was notified it was done. So the 72 hours, is that an outlier? Is it, tell me about that.
Unfortunately, I don't think 72, our policy actually is that urgent care should be turned around in 24 hours. There are lots of areas, lots of places there are no requirements sort of around that. But certainly automation has helped improve the turnaround time, but a lot of state laws, attempt to really push that into 24 hours, and that's what we would suggest. 15 minutes is fantastic, but that's certainly not the case for most patients.
Can I add just real quick? So certainly, as Emily said, some states have taken action in terms of requiring certain timeframes. So that 72-hour reference is sort of the outer, right? The outer limit. The other thing that I would say is that many health plans, because there may be a Medicaid plan, it may be a state requirement, they are an accredited plan based upon a national accreditation, that even if you don't have a state-specific requirement, that plans are held to turnaround times based upon keeping that accreditation. Now, the 70% that you mentioned, right, that's when both the health plan and the provider is accessing and using that electronic prior authorization process. And that's really, I think, the sort of light at the end of the tunnel, right? Like, that's the goal. If there's two-sided utilization of that process, it's much faster. As I said, if there are questions or, real-time further information that is needed, it can be done through that electronic system to get the answer quicker.
Follow up, Mr. Chair?
Go ahead.
Thank you. In my private business, I have been securities and insurance licensed for over 30 years, and I remember how amazing it was when the fax machine came out. The money I saved, things were going quicker. This technology, I thought nothing could ever replace it. Today, nobody uses a fax machine, and the costs are driven down. When I saw the statistics, and I believe you both talked about it on yours, I think it was page 8, Emily, about phone is a primary way of doing this. I mean, isn't that part of the problem, that we are relying on archaic systems when there's new technology there?
It's certainly part of the problem. And the investment for physicians, many independent practices or small physician practices in the technology that is needed is a huge hurdle, right? So we are working on solutions related to that. But I will say, that's part of the problem. I really want to stress how much we support automation, but the volume of prior authorization is also part of the problem, right? So if we can both move forward on automation, but also address the volume and the other barriers that are part of this, I think we can have that's a solution, not automation alone.
Thank you for your comments. Thank you for your questions, Senator. Our last commenter will be Representative Oliverson.
Thank you, Mr. Chairman. Just two quick observations. So Miranda, your slide was interesting to me. So while you were talking, I did a quick medical literature scan on hyaluronic acid in the knee. And did you know that there was a British Medical Journal article that concluded it was not of very much benefit, and literally that same year there was a systematic review that came out that said that it was. And so when we talk about, low value care versus high value care, are we really sure of the literature when we make these statements, or is it just sort of like, hey, we're picking and choosing the data that supports our conclusion as to whether it, because of, cost factors. So I don't really want you to comment on that. I just want to point that out, that it literally took me 60 seconds to figure out that the medical community is not universally agreed upon whether or not hyaluronic acid in the knee is actually beneficial or not. So the second thing I was going to say is, so could we all agree that prior authorization, using the word prior, is something that should happen before the medication is prescribed? Because what I see and what I have personally experienced as a patient is that my doctor continues to get hit with prior authorizations for medications I'm already on. I'm on a very expensive medication for cholesterol. It's this new one that you have to inject and all that stuff, and it's expensive. But we failed everything else, and I've had side effects with the other medications. We've already gone through the prior authorization process, and I haven't changed insurance. And yet every 3 to 6 months, my doctor gets slammed with another prior authorization for a medication that I'm on. Now that just disrupts continuity of care and harms a patient's ability to manage chronic disease. So can we agree that maybe that's not a good application for these kind of tools? That yes, go through the process. Once you've been through the process and you've passed, you don't get to keep dragging people back through the prior authorization process every 6 months.
So thank you. We're going to end that's something for you to ponder until next year. Thank you, Representative. We need to move on. Emily, Miranda, thank you very much. Senator Michelle, thank you for bringing this to us. Committee, we're going to go to item number 2 on the agenda, consideration of the NCOIL Value-Based Purchasing Model Act. Senator Felskowski had an emergency. She's not be able to be here. We'll hear from J.P. Weisky. It is our intent to take a vote on this. We've been working on this for some time. We don't know of any opposition. So, J.P., go ahead with your comments.
Yes, thank you, and thank you, everybody, for your consideration of this, this model. It's very simple. It allows, but does not require Medicaid and drug companies to negotiate a value-based, what's called a value-based arrangement, which allows supplemental rebates to pay for effectiveness of the medical care. So, for example, one of my clients has the hemophilia gene therapy, which costs $3 million. They're willing to warranty the effectiveness of that with Medicaid, and if it does not work within the first year, refund most of that money back. So that's what this bill does. It allows but does not require anybody to enter into these arrangements. Happy to answer any questions. Thank you.
Thank you, J.P. To the legislators on the committee, are there any questions or comments on this model?
Mr. Chair, I'm right by you.
Go ahead.
Do we need a motion on this?
Yes.
Okay, I so move.
The motion is to recommend the Model Act for value-based purchasing. Is there discussion to the motion? Seeing none, all in favor say aye.
Aye.
Opposed say no. Motion carries. Model Act is adopted.
Thank you.
Thank you, JP. Now we'll go to item number 3 and continue our discussion on the NCOIL Improving Affordability for Patients Model Act. At our spring meeting in April, we had a good introductory discussion on this topic, and then we continued in July with some new model language that was floated for consideration. Since that time, Arkansas Representative Deborah Ferguson, NCOIL immediately past president, and Texas Representative Tom Oliverson, current president, have agreed to sponsor the model language you can see in your binders on page 38 and on the website and on the app. We're not going to be taking any action on this today, just continuing our discussion. I'll stop there and turn it over to Representative Ferguson. Please go ahead.
Thank you, Mr. Chairman. I really do support this model, and I'm grateful for Representative Oliverson for agreeing to sponsor it since I'm leaving the legislature in January. We'll hear more from speakers today, but ultimately the model prohibits healthcare facilities, including hospitals, from inaccurately imposing hospital facility fees on outpatient services. It makes it difficult for private practice physicians to compete with the hospital rates. And it ultimately saves patients a lot of money if they're not billing hospital facility fee rates for truly outpatient procedures. I'll stop there, but let the committee discuss.
Thank you, Representative Ferguson. Representative Oliverson, would you like to add anything?
Yes, thank you, Mr. Chairman. So, I appreciate Representative Ferguson's leadership on this, and I'm honored to be able to co-sponsor this with you. I can just tell you as a physician, that the real problem here is that we have a loophole that's allowing facilities to charge facility fees for things that are done in the office by doctors or other providers that 10 years ago you would have just gotten one bill. Now you're getting 2 bills for exactly the same thing. We're not talking about MRIs, we're not talking about labs or physical therapy. We're talking about going to the doctor and seeing the doctor. You get a bill from the doctor, and now you're getting a bill from the hospital because it turns out the hospital actually owns your doctor. And that's something that I think is problematic on 2 levels. Number one, there's no added value being provided for that service, but there is a duplication of charge now being provided. And the argument is being made that that's in order to make sure that doctors are getting a fair reimbursement, but by my calculations, in no circumstances does 100% of the fee collected on the facility side make its way into the hands of the physician. If there was a reimbursement issue that needed to be addressed, then the way to address that is to address the reimbursement issue, not to create an avenue to allow a facility to suddenly leverage a healthcare provider's business. And secondly, to Representative Ferguson's comments, it deeply disturbs me to see the rise in consolidation in healthcare and how corporate the practice of medicine has become. I don't think that's good for consumers. You have to ask yourself, when the doctor's practice is owned by the hospital or the health plan, who's the patient advocate there? There's secondary gains and entanglements that cloud that medical practitioner's decision-making. And we need to be doing whatever we can to not incentivize more and more physician practices to become owned by large, consolidated, typically tax-exempt or not-for-profit entities that may have a very different set of financial goals and drivers than sort of your traditional doctor. And again, finally, I think there's a middle ground here, and I hope that my friends, hospital friends, can see that what we're not talking about here is limiting the ability to charge a facility fee in the setting where facilities are being used or there's ancillary services that are being performed where it would lend itself to a fee. What we're specifically talking about here is charging a facility fee for the privilege of being in the doctor's office. And there's no evidence whatsoever to suggest that there's any improvement in the level of service or care or additional services that are provided or quality that's provided by going to see a doctor who happens to be owned or practices owned by a large system versus a private, on their own practitioner. So I really strongly believe in this model. I do think there's a middle ground here, and I would urge everybody to come to the table and let's work this out. But let's get rid of the duplicate billing. I literally had a patient, a mother of a patient, reach out to my legislative office on Friday complaining that the large children's hospital in my district had just recently sent her a big fat bill because her daughter went to go see a sports medicine doctor and had a 15-minute consultation in the office and got a charge from the doctor, and then 2 weeks later got a $200 bill from the hospital. The patient never set foot in the hospital. There were no additional services provided. It was just a simple consultation and exam. So we have to do something about this.
Thank you, Representative. Now we'll hear from our presenters. With us today, we have Karen Davenport from the Center on Health Insurance Reforms at Georgetown University. And we have John Hawkins, President and CEO of the Texas Hospital Association. Thanks to both of you for being here. Karen, go ahead.
All right, let me see if I can get these. Oh, there we go, and move them ahead somehow. I'm sorry, I don't know how to use this. Whoops. There we go. Okay, I'm going to skip over the introduction other than to say we're part of the McCourt School of Public Policy at Georgetown and have a lot of legal and policy experts there who work on health insurance issues. I'm sorry, I know this works. Let's try this again. Back. Thank you. There we go. Okay. So I think we've already had a very helpful discussion of what facility fees are and what some of the issues are around them. We'll just say, facility fees aren't new. It's normal and accepted practice for inpatient hospital care, for example, for patients to see separate bills from the surgeon and the anesthesiologist and other treating physicians, as well as charges for the hospital. And I think we see that as well as more care has moved to the outpatient setting, similarly for procedures that patients receive. But as hospitals buy up outpatient practices, consumers are seeing more and more facility fees attached to routine ambulatory care and office visits that don't require hospital admission or a hospital level of care. And I think that's where the consternation largely lies, certainly on the side of consumers and payers as well, because the quality and safety and intensity of the care you get may often be totally unchanged just because your physician's practice has been purchased by a hospital and is now operating as a hospital outpatient department. So why should policymakers be concerned about the wider application of facility fees, including in settings that before a merger were a plain vanilla doctor's office and still look like a plain vanilla doctor's office to patients who continue to see the same healthcare professionals that they've always seen? In our research, we talked with consumer advocates, insurance plans, and other academics, and several reasons came up. First, consumers are facing higher out-of-pocket costs for outpatient care. That's partly because they're carrying larger deductibles, so they really feel any extra bill. But also with two bills, even patients who've met their deductibles or have low deductible plans can face significant cost sharing. That's because two bills can generate two cost-sharing payments, perhaps a co-payment for the physician visit, but also co-insurance for the hospital's bill. Consumers, and for that matter, their employers, also face higher premiums thanks to higher spending on outpatient care, with that spending driven in large part by the growth of facility fees and the application of those fees to regular office visits. Consumers who can't afford to pay cost sharing related to facility fees may also decide that they need to find a new provider who practices independently and therefore doesn't charge facility fees. That is, if they can find them, given the higher level of vertical consolidation that we have in so many healthcare markets. And between the higher costs that consumers experience and often the frustration of not even knowing if they would be hit with higher out-of-pocket costs, consumers experience a lot of confusion and anger. Payers are also incurring increased costs for ambulatory care, as is the healthcare system writ large. And to the degree that facility fees create an incentive for hospitals to create more ambulatory practices, to acquire more ambulatory practices, insurance plans have less leverage as they negotiate rates for outpatient care, since they must negotiate with larger, sometimes must-have systems for their networks and end up paying more for these services. So some states have enacted legislation or pursued regulatory reforms related to facility fees. We did what felt like an exhaustive look at all 50 states plus the District of Columbia and the reforms that some of these states have taken. And we see reforms that typically seek to address one or more of three issues. That is the problem of increased consumer out-of-pocket cost exposure, rising healthcare system costs, and limited information on facility fee billing and outpatient practice ownership. We've categorized the responses that states have taken into 5 buckets: banning facility fees for some or all outpatient care, new billing and ownership transparency requirements, public reporting requirements related to facility fee revenue, limits on consumer cost sharing for facility fees, and consumer notification requirements. You can see that kind of cute effectiveness meter down there on the lower left. We have a cheat sheet for policymakers that I think is in your materials and is also available on our website that goes through all of these solutions and makes some assessment of how effective they are. We also have on our dedicated webpage that highlights our facility fee research a series of interactive maps that quickly illustrate which states have pursued which reforms and gives a little bit of a snapshot of what those reforms are. I'm going to go through a few of those, but probably not all of them in the interest of time. So the most assertive policy response states have taken to the growth of outpatient facility fees is to simply prohibit facilities from billing commercial payers for these fees for some or all outpatient services. State laws typically define these prohibitions by types of service or by setting or both. A number of states have banned facility fees, for example, for telehealth services, while others have banned them for preventive services. Indiana prohibits nonprofit hospitals from charging facility fees for off-campus services, and Connecticut prohibits facility fees for outpatient services provided both on and off the hospital campus that are billed to evaluation and management or assessment and management codes, so for a basic office visit, essentially. And then Maine prohibits facility fees for services provided in on and off-campus office settings. That ends up having a fair degree of interpretation, but that is the language of the Maine statute. And I've noted on the slide that these prohibitions help consumers with costs related to facility fees, arguably, these bans may also reduce system-wide costs, but that really depends on, the subsequent rate negotiation between the providers and the payers, where they may be able to negotiate higher rates for other services, for example, to compensate for reduced facility fee billing. Another strategy that is generating increasing attention, including in federal legislation, although I don't think that bill's going to go anywhere in the next 6 weeks or so, relates to billing transparency. Right now, payers often cannot tell where care is delivered because the facility can bill at the sort of umbrella or enterprise level and use the main campus address, or sometimes even the billing address, which can be out of state. 3 states now require off-campus hospital outpatient departments to acquire and use location-specific, unique national provider identifiers when they bill for facility fees. This requirement gives payers and potentially researchers and policymakers more information about when and where hospitals are billing outpatient facility fees and for which services. In particular, it allows payers and researchers to link healthcare professional bills and hospital bills to understand how much is really being billed and paid for given services delivered in a hospital outpatient department. You can see that these have so far passed in Colorado, Nevada, and Nebraska. We'll also say it's not reflected on this map, but Colorado and Massachusetts also require hospitals to provide updated information on their affiliated outpatient practices. So those unique NPIs can also be mapped to the larger systems that own those practices. I'm going to skip over public reporting and oversight, other than to say that a number of states do require hospitals to report on their revenue, often by service and also by volume related to facility fees. And then 3 states have had recent studies on facility fees. Maine and Colorado have wrapped up those studies. And then Maryland has just kicked one off that was required by legislation in 2024. I'm also going to skip over coverage and cost sharing protections because those we only have Colorado and Connecticut that are doing those so far. But those are other strategies for limiting consumers' out-of-pocket liability related to facility fees. And then finally, I'll touch on consumer notification requirements because those are by far the most popular approach that states have taken so far. States can have required facilities to notify customers about consumers about the facility fees that they charge at the time that the patient makes an appointment, or via signage at the point of service, or both. Some states also require facilities to notify a practice's patients when they acquire an outpatient practice and alert them to the fact that they will now be charged a facility fee when they receive care at the practice. I think that there is, certainly improves transparency for patients to know that they will incur a facility fee. And I suppose there's a glimmer of a chance that this can also reduce system costs, but I think that's ultimately unlikely. Particularly if you learn about a facility fee from signage when you're in the office, which was my first experience with facility fee billing. Patients, often grit their teeth and go ahead with their visit and deal with the bills when it comes through. Patients can also try to change providers and thus avoid the fee, but as I mentioned before, that can be a very difficult thing to do in markets where there's a high level of vertical integration. So it can be more of a theoretical than a real option. With that was my whirlwind trip through our 50-state review of facility fee laws, and thank you so much for your attention.
Thank you, Karen. We appreciate your comments. John, go ahead.
Thank you. Thank you, Mr. Chair and members. I appreciate the opportunity to present to you today. And very much appreciate Dr. Olverson's entree into this about what we're really looking at is trying to deal with the bad actors out there, but not do it in a way where we limit access to care or actually shift cost onto other areas of the system. So I very much appreciate that, and I appreciate the hearing you had earlier this year where we teed this up. We're concerned about a broad prohibition on facility fees because we believe there are cases where those fees are legitimate. I will point out that a lot of what we're dealing with in the healthcare system, unfortunately, is cost shifting from other areas. that have to be recovered in those fees, and I would argue that's appropriate, but we ought to be looking at strategies to manage those costs down ultimately, and I'll touch on a few of those. I'll just remind you, hospitals are the only sector of the healthcare system where we're required by federal law to take all comers, regardless of ability to pay, and that's a key part of the commitment to communities that come with a hospital license. Hospitals and health systems are not monolithic. They all have different payer issues related to the communities that they serve. Hospitals provide standby capability and disaster response. There is no explicit funding for those safety net services. And then we're continuing to deal with inflationary challenges, and certainly coming out of the pandemic, nursing shortages, physician shortages, other allied health professions, that cost is being borne by the healthcare system as well. That's why we asked last session for our legislature to invest in the workforce pipeline, and they stepped up and did that. Again, those aren't immediate, but those are long-term things that could help us going forward. Hospitals typically care for a higher proportion of Medicare and Medicaid patients, and I'll remind you that Medicare typically pays about 82 cents on the dollar, so that's about $100 billion annually in care that's provided that is not reimbursed, that's getting shifted elsewhere. Medicaid typically pays about 87 cents on the dollar. That's another $31 billion shortfall. Add to that care for the underinsured, uninsured, and uncompensated care in a state like Texas that leads the nation in the number of uninsured. That equals $3.1 billion in uncompensated care just in Texas, and that's at cost. And it's not just the government payers. We are dealing with insurer underpayment in other areas, particularly in behavioral health. We have data that shows there's about a negative 35% margin across all payers for behavioral health services because those are not paid for equitably under private coverage. And then we had a discussion earlier about all of the red tape from insurer requirements, and that's a cost that has to be dealt with. So I do want to just talk a little bit about the commentary about consolidation. And I think that is an issue that needs to be dealt with. We know that most of the consolidation actually has been in the payer, health insurer, and in the private equity space, and that is certainly not helpful. I would argue that in most cases, particularly in more rural areas of the state, our hospitals are stepping in because the physicians who are reporting their inability to continue to practice because of their inability to negotiate with payers and the red tape from dealing with those payers, they are looking to exit the market. And so they have the option of going to their hospital health system, going to private equity, or going to a payer group. And most of the times our hospitals are stepping in to partner with those groups to ensure those services stay within the community. And that involves some level of subsidy. I'll agree with Dr. Olverson. There's probably a legitimate discussion about how much of that actually ends up in those practices. But really, that is the last case to keep those ability to keep those services in the community. And so, we wholeheartedly support increased physician rates for Medicare, Medicaid, and in the private space to reduce that incentive for that consolidation because there are legitimate cases for facility fees, there are not legitimate cases, but that forced consolidation is, as Dr. Olverson pointed out, is not necessarily helpful to the overall practice of medicine. So I'll stop there and certainly
John,
answer
thank
any
you very
questions.
much for your comments. We'll have time for a question. Senator Lang.
Thank you, Mr. Chairman, and thank you to my colleagues from Arkansas and Texas for bringing this forward. I do think this is a very important bill, and John, I understand what you said about these fees are necessary. Quite honestly, I'm really not buying that. But I do think we need to give some consideration to the hospitals in this scenario, and I'd like your input on this. I assume when you buy a practice, you base it on a multiple of EBITDA or a multiple of something. Let's pretend it's EBITDA. And instead of giving a 6 times multiple, knowing you can recoup a higher investment from charging a higher facility fee, you may offer an 8 times EBITDA just to sweeten the pot for the practice. So my concern, and I'm assuming your pro forma is a 5 to 7 year break-even pro forma, only based on my experience in the private sector. I don't understand your business model, so these assumptions of mine may be way off. So my concern is, if we put this in place and we just make it across the board, we are forcing hospitals to take a loss on their pro forma, and it will result in cost shifting. They're not going to eat that loss. They're going to shift the cost. So, and Dr. Alverson, I'd like you maybe to weigh in on this because of your private practice experience. Should we give any consideration to a grandfather? And I'll make these numbers up. If a practice was purchased in the last 5 years, there's a 3-year grandfather clause where they don't have to comply, but any new practice on a go-forward basis has to comply immediately. That way we are not forcing the hospitals to lose money based on an offer they made 3 years ago in a pro forma based on the rules at the time that we since have changed. I'd like everybody's input on that. Thank you. Thank you, Mr. Chairman.
Yeah, no, I think that makes sense. I mean, obviously, there are business considerations that have been dealt with in those situations, and sometimes that could be problematic. I would argue, ultimately, the market is going to normalize some of that distortion if there are folks out there who are outliers or bad actors. But again, I would certainly entertain something that would look at grandfathering. Again, I don't want to protect necessarily bad actors because I recognize those aren't helpful, but it's worthwhile for discussion.
Thank you. Appreciate the comments. Thank you both for joining us, and we look forward to continued discussion on this issue next year. Committee will now go to item number 4 on the agenda, discussion on developments in vision care services legislation. It's on page 49 in your binder. We have laws from Texas and Oklahoma that will be referenced during the discussion. The goal of the discussion by the committee today is to get an update on these laws and see if there's an appetite to further discuss these issues next year. We have a few speakers with us today. Let's start with John Peterson of the American Optometric Association, and then we'll go forward and we'll hold questions until the end. John, go ahead.
Thanks. Thank you for having us. I'm Dr. John Peterson with the American Optometric Association State Government Relations Committee, and I'm also an independent practitioner just outside Denver, Colorado.
Hi, I'd like to introduce myself as well. I'm Dr. Tommy Lucas, here from Texas. I'm a private practice optometrist about 2 hours from here in Killeen, Texas, and I represent the Texas Optometric Association as well.
Thank you. Go ahead.
All right. So just introduction to the topic of vision benefit managers. So vision benefit managers are entities that sell vision plans and utilize their market powers to gain significant control over the vision care industry. Vision plans typically provide wellness eye exams and discounts on contact lenses and glasses. So they are not entities that cover medical eye care such as glaucoma, macular degeneration, diabetes, things like that. All of the medical eye care is the coverage is provided through medical plans. So right now, we run into the same issue that has been discussed ad nauseum this morning with vertical integration and large market share influencing care. Right now, there are 2 VBMs that control about 70% of the market share. And I think at some point there will probably be a slide shown that shows a plethora of vision plans, and that's really, there's really 2 of them that control the most. In certain states, in over 40 states, there's one plan that has a plurality of covered lives in that state. So when the VBMs have this market share, it does dictate and limit choices for patients and providers and interferes with the patient-doctor relationship.
Yeah, happy to be here with you guys today. Definitely, this is a story of vertical integration that we've spoken about this morning and also market concentration. So what issues do us as optometrists have with the VBMs? Let me say first off that, having patients that have a vision plan is generally a good thing. We want patients to have coverage to get an eye exam because what optometrists do are detect eye disease, and we help people fix their optical misalignments, their optical correction. So those are needed services, obviously, that are important to society for a multitude of reasons. When we have a wellness eye exam benefit, it helps us detect those diseases, catch them early, save costs, all of those things. So the contention between us and the vision plan industry, the VBM market at this point, is not that vision plans are not valuable. It's the controlling techniques and the impacts on small business, my practices just like mine all across the country, and the patients that I serve. Knowing that vertical integration and market concentration are the main issues, the 5 bullet points on the screen you see there are more of the specifics of what's going on. So we see specific instances of anti-competitive behavior towards optometry practices. The VBMs have now bought up the entire supply chain, of course, from manufacturing, wholesaling, distributing, retail, and they own the vision plan that steers patients to those particular products. So when you're an independent optometrist and you're having to care for your patients in this environment, obviously those incentives to use those products impact your business and impact the quality of care that you're providing to your patients. When a VBM is dominant in a particular community or state, basically the contracts that we're presented, and that's how this works. Like an optometrist like myself will just get on the internet and say, hey, I'd like a provider contract for the biggest VBM company. We'll apply for that. They'll send us a contract in many cases, and then that contract is basically non-negotiable. When I first started working in this space about vision plan reform, I did not really understand what a contract of adhesion was, but it's kind of what we're dealing with here from a legal circumstance. So we basically have a non-negotiable contract where if we want access to the patients that are covered under that, we have a take it or leave it situation. And then in that contract, there are a lot of issues where the VBM will force the doctor to use a certain product that the VBM owns. They'll force the doctor to use a certain lab that the VBM owns. They will, have specific auditing techniques. They'll have provisions about, provisions about the. I'm losing the term here, guys. I'm sorry. I apologize. A little nervous in this environment. So I'll just move on. Thank you. So contracts of adhesion are a big problem. Access to care concerns, obviously. When the VBM is controlling all of this, where does it stop? Where does it end? Where we're going to have enough providers to care for the patients, or are they all going to be forced to go to the locations that they own? Interference in the doctor-patient relationship. Dr. Oliverson, alluded to this. When there's a financial incentive to that doctor to do a certain thing, we kind of lose that sanctity of that doctor-patient relationship, where there's an incentive in the middle of that relationship, and then you're not actually getting unbiased, proper care in many cases, and sometimes quality care. So those are some of the impacts on optometry practices that we're having with VBMs. So, and this is why VBM reform is needed. These bullet points here, of course, maintain healthy competition. We see market concentration on the retail side where the services are actually being performed. The monopoly conversation, or in this conversation, more of a duopoly is going on. And like the last conversation, we've acknowledged that there were rising rates and prices in the context of market concentration. Well, that is where this story in the vision plan market, of course, will end too, naturally, and we're obviously concerned about that. Patient choice is a big problem. If a patient only has a certain menu of items that they can get with their care, that's a problem because it may not be appropriate for that patient. Improving transparency generally is a problem. Sometimes the benefit plans are fairly convoluted, and patients and doctors don't understand those plans. And whether that's done on purpose or out of necessity, either way, it's a barrier to care. and then maintaining clinical independence. At some point, we have to let the doctors guide the course of care for that patient as opposed to letting a insurance company dictate that level of care. So what's been done about VBM abuses so far? This is not a new consideration. This has probably been about a decade-long effort where states have looked at these issues and decided to make various reforms. Right now, we have 27 states across the country that have had some measure of VBM reform. And of course, home state of Texas is one of those, and I want to kind of highlight that. So this is where it gets a little bit more in the weeds about the prohibitions that the Texas law and the Oklahoma law, which are the two most comprehensive state laws at this point, have in those laws. So you'll see that the state law in Texas now prevents any price fixing on non-covered services. Obviously, that's very important to a small business when a plan covers what they cover for the price that they're covering it for, and determining the actuarial science that goes into that. Well, then interfering with non-covered services impacts that small business in a very significant way. The laws prevent the misrepresentation of what covered services are. Sometimes language is used that makes things seem covered when they're not. Dictating the glasses manufacturing lab is a very big deal. A lot of times optometrists can make glasses quickly, sometimes in their own lab or a lab in the community versus a lab that's many states away that may have a lower quality of care that's being dictated. So the state law in Texas and Oklahoma and many states prevent that forced lab choice at this point. The steering of patients is a big deal. At this point, we have the Texas law prevented for the first time steering to cell-phone locations. So as the VBMs have bought up the have started buying up retail locations, the Texas legislature decided that, well, having that VBM push patients into their cell phone locations is not in the best interest of access and care. So that has happened in the Texas law. The tiering and ranking of doctors was also occurring and still is occurring to this day. What will happen in this case is, like on a doctor locator, the VBM will give a gold star to a certain doctor versus a silver star to another doctor. And what the gold star is based on is how much product that doctor is buying from that VBM. So it's no indication of quality of care or anything like that. It's just simply how much money are you sending our direction and reselling that to the patient. So that has
Tommy,
been out.
just so you can manage your time, you have 2 minutes left.
Thank you. And hiding out of network benefits. So what we've seen in response to the law is the two top VBMs immediately closed their panels in Texas following the passage of House Bill 1696. They've evergreen contracts as well, so most doctors are actually operating under their previous contract before the law went into effect. Now they have sued the state of Texas over this law, and that's working its way through federal court. Threatened unintended consequences in many settings, and they have purchased more large retail optical chains. Right here, this happened about a month ago. The largest vision plan in the world bought a very large retail group that provides care, 250 locations, and you see their revenue, knowing, kind of EBITDA and what the gentleman was speaking, this is probably a $1 to $1.5 billion transaction. So the profits that these VBMs are making are being used to buy up the industry.
Real quick, these are some of the other things that are being done on a national level. He spoke to all the states that have passed this. So second thing there, Dental and Optometric Care Doc Access Act, that is something that is being done. Unfortunately, with a lot of these plans, our ability to fight this at the state level is troublesome because there are ERISA plans at a national level that allow the VBMs to skirt around the issue in that sense. This is Representative Comer from Kentucky. He is opening an inquiry on his committee into the vertical consolidation and transportation or transparency. These are some of the things that will be mentioned as reasons not to consider VBM reform. As far as costs going up for premiums, the premiums are not the profit center for these plans. As Dr. Lucas mentioned, vertical integration is the major problem here, and the profit centers come from them owning retail locations, material locations, electronic health record system. Even the system that we use to file most of our claims is owned by one of the major BBMs. So the premiums are not going to go up. Really, the cost will go to onto the patients, because the patients will be forced into situations where they're buying products through these vertical integrated plans. And in general, these are companies that are making tens of billions of dollars. We're a very small driver in the healthcare cost market. I think that's it from us.
Thank you.
So
Thank you for
sorry
your
for running over.
Thank you for your comments and your presentation. Just so the committee knows, we started 10 minutes late due to the emergency for our first presenter. It's unfortunate, but our intent is to continue this committee until about 11:40. Next, we'll hear from Lisa. She's the Vice President of Government Affairs, National Association of Vision Care Plans. Welcome, Lisa. Go ahead.
Thank you. Hi, good morning. My name's Lisa Ann Hurt Forsyth. I'm the Vice President of Government Affairs for the National Association of Vision Care Plans. Just wanted to respond to some of the comments and introduce some data that I think will be interesting for you. This is a very recent study that I think is really important because it shows the value of vision care as a critical benefit. This was a Harris poll. It's not a Lisa Ann poll. This was done recently, and it showed that 94% of full-time employees aged 25 and more indicated that they said vision benefits were very valuable, so they see value in having vision care insurance. Many, 82% cited it as equally important as having general medical insurance. And I think my colleagues would agree that there is definitely value in having vision insurance. Vision health was also ranked as very important by 75% of the folks that responded to the survey. You should have a handout. I know some of them ended up on the floor when the wind blew, so I'm sorry about that for those of you who don't have them. It sort of is a synopsis of what I have in the slides. The other thing that's important is that demand for vision care is rising. Quite frankly, myself included, there are a number of us in this room that fall into the category of the aging population, and screen time, quite frankly, has contributed to more of us needing optometric care, quite frankly. So there's a greater demand, actually, for the services of the folks sitting at this table. As my colleagues mentioned, regular eye exams are really important. They do detect underlying health conditions, and you see several of them listed there, particularly for the high blood pressure and the heart disease. Those are some that you might not necessarily think of. If they are identified early on by practitioners, it can help when there's communication with the primary care physicians to get involved in those medical conditions early. Maybe something you didn't think about when you think about vision care. So in terms of access to vision care, I put a slide here to show you what % of covered lives of folks have general health care coverage versus vision care coverage. And you can see there's room for growth in the vision care market. So for example, if we're looking at state government employees, 95% have some sort of medical coverage, probably not surprising to anyone in this room, but only 42% have vision care. So there's some room for growth there. And then you can see some of the other categories here as well. Trying to go quickly here. So here's where the rubber meets the road. Affordability is what drives the access to vision care. For the vast majority of the population, how much money someone has to pay out of pocket will determine whether they will go and seek vision care or whether they won't. So this is from the Kaiser Family Foundation, recent study that was trying to find out what kind of medical services by type do people forego if they don't have insurance coverage, ergo they can't afford it. First is dental, and I mean, some of us might forego dental even if we have coverage, but that was the first category. The second category is vision. If they don't have that coverage, that's the second most likely category that someone is likely to forego altogether or delay if they don't have the coverage. So where vision plans add value is that we help to mitigate those out-of-pocket costs. So we help people to manage those expenditures. Insurance coverage is an independent predictor of vision health, i.e., if you have that coverage, you're more likely to go and seek vision insurance, and you're more likely to have better eye care, and have things detected earlier, as I mentioned on that previous slide. You can see here about the patients surveyed, said they had, a third of the patients surveyed reported that they had eye exams less frequently than they would have liked to, simply because they didn't have the insurance to cover it. So here's an easy. 0 to $20, average copay if you have vision insurance to go and get that wellness exam that my colleague mentioned. If you don't, you're looking at $200. For some people, $200 isn't a big deal. For a lot of people, $200 is a huge deal and make the difference between making your rent payment or not making your rent payment. If you are in that category, of which there are a lot of folks, this is what leads to what I was saying on the prior slide, that people just say, I can't do it because I don't have coverage. So I want to shut down this VBM business. That is not a thing. That is a manufactured acronym that is designed to create an analogy between vision care plans and PBMs. But there really is nothing similar about the two whatsoever. This slide sort of shows you the difference between the two. PBMs operate largely in a black box. People don't know what's going on. It's opaque. They don't save money for folks. They're a cost driver. And as I'll mention in a moment, our vision care plans not only have kept costs lower for consumers, not only for premiums, but also for their out-of-pocket expenditures. If we were to be operating as a monopoly, from an economic standpoint, we are doing a horrible job because our prices have actually gone down. If we were becoming a De Beers or something that we consider when we're thinking of a monopolistic impact on an industry, we expect to see a reduced supply and increased costs, and instead we've seen the opposite in our industry. So if we were doing what has been alleged, we're doing a very poor job at it, quite frankly. There was some mention about vision care being a crowded field. There are lots of players in the field. There are not just two. There are many folks that are operating in this space, and there's a lot to be done in this space. As I mentioned, there's a lot of room for growth, and there's a lot of opportunity in this market. I mentioned vision premium rates have trended downwards. They've trended downwards because the number of lives has increased. It's basic economics. As the number of lives increases, the price per life goes down. That is not true if you look at the graph on the right-hand side, and I'm sure I don't even need a graph to tell you this. Healthcare expenditures overall have skyrocketed. So we're sort of one of the few bright spots in healthcare, quite frankly, from a price and a consumer perspective. This is talking about the number of optometric practices. Contrary to some assertions that have been made, the number of optometric practices that, this is Census Bureau data, again, has increased to a high level that it's never seen ever. It's at its highest level that it ever has been. This is in stark contrast to physician practices, which you will see on the right-hand side, many of which were discussed with Dr. Oliverson earlier with regards to being bought up by larger practices, et cetera. We're definitely seeing that consolidation and M&A activity on the physician side, but not on the optometric side. And this data bears itself out state after state. I've run it for many states, and we see the same upward trending line. So really, this is good news that we are expanding the number of practices. So we talked about legislative solutions. There can be some negotiated middle ground solutions, and these are some states where that's happened, where there has been an open discussion about how to approach any issues and come to a collaborative solution. So there are some states where that has been successful. The focus needs to stay on patients, access to care, and the end cost to the consumer. That's what we need to stay focused on, patients and consumers. So I want to talk a bit about the Texas legislation that was mentioned and the Oklahoma legislation in closing here. The Texas legislation was enacted last year, and its constitutionality is being challenged in federal court. There is already a preliminary injunction in place. The judge has heard it, and was concerned with the anti-competitive nature of some of the terms in that legislation. So it has been prevented from being enacted at this point. We expect to see some further information over that over the next couple months. There was also legislation introduced at Oklahoma. Again, there was significant opposition to many of the terms that were contained in that legislation, and it was in fact vetoed by the governor, largely over concerns, again, on the impacts to consumers and patients. This is in closing. The vision care insurance market is stable, it's affordable, and it's essential, as I mentioned before. Employees overwhelmingly value having the vision care insurance. It's a critical health care need. The demand for vision care overall is increasing, as I mentioned before, and there's great market expansion potential in this area. Vision insurance helps these folks to manage their out-of-pocket expenditures, which therefore makes it much more likely that they will go out and seek care. And going and seeking care is associated with better vision health, as we mentioned before, and early detection of underlying medical problems. The number of optometric businesses is continually increasing, as I showed on that graph before. It has outpaced, in a great way, the growth rate of physician practices overall. So it is an inaccurate statement to say that the number of optometric practices is going away, decreasing, or whatever. The data just does not bear that out, quite frankly. And as I mentioned, collaborative legislative solutions are definitely what is needed. We need to come to the table to work through any potential issues that might exist and make good public policy decisions that are data-based as opposed to assertion-based. Thank you.
Thank you, Lisa. We'll take time for one question. We have Senator Boyd.
Just to clarify, I really had two questions, but since we're going to do one, I'm going to ask the first question. So in that slide,
You can
where
only have
had
one
the
question, but it can have two parts.
Okay.
There you go.
So
A and a B. You get an A and a B.
So the first part is that slide where we're increasing the number of optometric practices.
Yes.
So we see the PBMs in pharmacy. They come in and they say pharmacies are actually not decreasing. And so what's happened in the pharmacy world, and I'm just curious, is now that the world is so complex with insurance and government, that many brick and mortar pharmacies actually have to have more than one NPI number. So are you actually measuring the number of brick and mortar practices when you report that? Or has optometry become complicated and now you have to have more than one NPI number? How are you actually getting to the number to show that the practices are increasing?
That's an excellent question. I actually pulled the data directly from the Census Bureau using the county level tables, and those are from tax filings of individual businesses. So that is the number of optometric businesses, and it's right from the census data.
Okay.
And you
then-
can pull it all the way down to the county level, actually.
And so then I don't want to be too complicated, so I'll just kind of ask a question.
This is the
So,
B, it's okay.
Again, I hadn't heard of a VBM until today, but I've
Right.
certainly heard of PBMs quite regularly.
Of course.
And so, the Federal Trade Commission had come out with something that showed there was a leukemia drug where it was $27,000 at the preferred pharmacy, $19,200 at the PBM home delivery pharmacy, and $97 at the non-preferred pharmacy. And so when the same people who are setting the price and making the payment and own the entire supply chain, doesn't that create a lot of opportunities to have, misincentives for the consumer?
Yes, theoretically, and certainly that's been seen in the PBM market, as you mentioned. But as I said earlier, VBMs, that's a non-existent acronym that's been created to sort of create this artificial connection between vision care insurance and PBMs and sort of draft off of that type of example that you just mentioned, which is excellent. What we've actually seen in terms of pricing in the vision market is, as I mentioned, the premiums have actually decreased and prices have held very stable. So we really haven't seen that kind of variability that you're describing that definitely permeates what's seen in the PBM market. So thank you, I appreciate the question.
Thank you, Senator Boyd. So to our panel, thank you, Tommy and Lisa and John. If there are any committee members that want to continue this or pursue this for next year, please let either myself or NQUAL staff know. Thank you very much. Now, our last item on the agenda, item number 6, we're going to have a brief introduction from Kentucky Representative Deanna Fraser Gordon, who's going to introduce the topic for next year regarding hearing aid classification model law concept. Representative Gordon.
Yes. Thank you, Mr. Chairman. Is this microphone on? Okay. Thank you, committee. In your binders on page 77 and on the website and the app is a bill I sponsored in Kentucky that is very straightforward and is something that I'd like this committee to consider taking up next year. It deals with changing state law in light of recent regulatory change from the FDA regarding a new classification of over-the-counter hearing aids, thereby making traditional hearing aids prescription devices. That classification has resulted in confusion among practitioners and policymakers at the state level, which is why the change in law is necessary to clarify things. Because the FDA does not have jurisdiction over practitioner licensure, it's up to the states to further define. I am an audiologist, so I can speak firsthand to the confusion that this has generated, and I look forward to discussing the issue further here next year. Thank you.
Thank you. Thank you very much. So this will be continued further next year. Is there any additional business to come before the committee? Thank you. I'll entertain a motion to adjourn. So move second. Second, all in favor say aye. Aye. Opposed say no. We stand adjourned. Okay. There'll be a 5-minute break and then the next session begins in 5 minutes.